Ladies and gentlemen, it gives me great pleasure to welcome all of you in this series of webinars I'm organizing as second vice president of the World Federation of Neurosurgical Societies in collaboration with the Egyptian Society of Neurological Surgeons and the Continental Association of African Neurosurgical Societies. Important to tell you that we already organized 37 webinars since the beginning of the pandemic. I also organized 7 educational WFNS symposia. Today is webinar number 38 among our series of webinars, and it is about neuro-oncology. Let me welcome our keynote speakers. Professor Alvaro Cordoba is consultant of neurosurgery at the British Hospital in Uruguay. Professor Abdelnabi Isa is professor of neurosurgery at Clinic Rafiq El Fath, Algeria, and he is former president of the Pan-Arab Neurosurgical Society. Professor Kiki Torelli is chief in the Department of Neurosurgery, Bombay Hospital, Mumbai, India, and he is chairman of the Complications in Neurosurgery Committee of the World Federation of Neurosurgical Societies. Professor Ahmed El-Ali El-Morsi, he is a consultant of neurosurgery at Zaghazigh University in Egypt. Thanks to all of you for contributing to this neurosurgical activity and for giving us much of your time, sharing your knowledge and experience with young neurosurgeons, especially at this difficult time of COVID-19 pandemic, is well appreciated. We have very interesting topics today. We have confocal neuroendoscopy in brain tumors, awake surgery for gliomas in eloquent areas, operating around eloquent areas for gliomas of the brain, and brain mapping era in neuro-oncology, the Egyptian experience. As you can see, this is the last symposium we organized, the WFNS symposium. We have a very good participation over the Zoom and over the YouTube channel and Facebook page. We are doing live stream over Facebook page of KANJ, and this is the address. And also we are doing a live broadcast over the YouTube channel of the Egyptian Society of Neurological Surgeons. For all attendees, we are glad to get all your questions and comments, and this will be monitored through the chat panel or the Q&A. We are offering certificates. This is the link by which you can print your certificate electronically for all participants. The username will be the email by which you register to this webinar, and this is the password, ESNS@1967. This is the certificates you are going to print electronically. Just allow 2 days in order to put all emails of all registrants over the system. Let me make an announcement about next Friday webinar. This is going to be webinar number 39. It's going to be about current and future directions in neurosurgery, African-Asian collaboration. It's tripartite seminar, which is collaboration between 3 organizations: the Asian Congress of Neurological Surgeons, the Egyptian Society of Neurological Surgeons, and the Continental Association of African Neurosurgical Societies. And we are honored to have Professor Yuko Kato as organizer. I'm the organizer of this meeting with Professor Yuko Kato and with Dr. Sharon Theophilus from Malaysia. We have speakers. These are the keynote speakers for next Friday. We start early. We usually start at 2 p.m. Egypt time, but next Friday we start 11 a.m. and this activity will take 4 hours. Also, I'd like to announce about a meeting I'm organizing in Egypt, which is the Third Man's Congress, 27 October 2021. And this is the Mediterranean Association of Neurological Surgeons, but there is possibility that it's going to be postponed to the next year, and it depends on the situation of COVID-19 pandemic. Maybe, of course, all of you are invited to join this important meeting, whether it's done this year or next year. and maybe we will have a good opportunity to visit the Grand Egyptian Museum together. Thank you very much. I think now it's time to proceed to scientific events. May I ask our first speaker, Professor Alvaro Cordoba, to start his presentation.
Yes, perfect. Well, good morning, everybody. Can you see my presentation or not? It's okay?
No.
Not yet?
Not yet.
Just a moment.
Okay.
And now?
Yes, now it's very good.
Perfect. Thank you so much.
Thank you.
Well, thank you so much, Nasser, and all of my friends in Egypt and all of the association. It's very, very important for me to stay here to be part of this activity. And I will show you in very brief presentation our experience in this kind of technique, because we are very, very nosy normally in neurosurgery and neuroendoscopy since a long time ago, when it started in 2002 with our experience in neuroendoscopy. We try to learn a lot of different things and tips and tricks in neuroendoscopy. And one of the last was the confocal endoscopy that we found very, very interesting in the field of neurosurgical performance and activities and techniques, mainly in brain tumors. The name of confocal is perhaps in relation with the confocal microscopy, normally in histology procedures that the pathologists normally use in the common techniques in neurosurgery. But with the development of the confocal optics in neuroendoscopy, in neurosurgery a long time ago, the first one was in 1989, was the term, the name of confocal endoscopy is introduced in neurosurgery. The first procedures was developed not in neurosurgery, was by the urologists and the NT surgeons made it in laryngeal tumors, laryngeal process. So it's very interesting to apply like a microscopic procedures in neurosurgery that is possible to use different instruments that another specialized in neurosurgery. So it's possible to use this kind of optic normally like the common technique in neurosurgery and neuroendoscopy, like a small microscope during the resection of the tumor, in order to put in the surface with a lot of steiners, normally the common steiners used in histology, and sometimes with fluorescence, than the last generation of confocal endoscopy. It's possible to test in the micro range structure of the tumors. It's possible to see also the small cells of the tumor in order to check the border of the resection. That is very useful and very used by the urologists, mainly in bladder tumors, and it's possible to learn about their experience. We have no conflict of interests. We start with neuroendoscopy a long time ago, doesn't matter actually, but for us it was very important, which is start with without the support of the companies, and only was a very enthusiastic procedure for us. It's a long time ago, and actually we developed a lot of patients. This is our small experience about that, but normally in brain tumors and in assisted microsurgery is a very novel and very nice field to use the neuroendoscopy and to learn about a lot of things, mainly in brain tumors. So in confocal endoscopy is possible to use in brain tumors, and it is the subject is possible to apply. For the first time that we think something different about tumor surgery, we try to introduce the tumor brachytherapy. So we put in the past a small wire with the use of iridium inside of the endoscope. Was the first attempt that we tried to use in different way the endoscopy, and it was very, very useful for us. So we are in continual thinking about how to improve perhaps different things and the common techniques in neuro and neuroendoscopy. You see here a very huge astrocytoma was operated by the classical approach. Was in 2005, I remember, and we tried during a recidive to use this kind of technique with endoscopy to introduce the brachytherapy inside the tumor. We put inside, you see here, a small wire inside of the endoscope. This was a long time ago. It was the first attempt to do something different during a brain tumor resection. Actually, we try to use this kind of technique with focal endoscopy in combination with another techniques. We introduced 3 years ago also the axial navigation, the electromagnetic navigation. So it's possible also to use in combined with this kind of technique. But we never forget the past, because we started in the neuroanatomy department in Montevideo, and I'm very enthusiastic always and to repeat to the residents that we must not forget all of the classical authors in anatomy, because the Professor Raymond Viozan developed this kind of very fantastic book about all of the tracks, fibers. Actually, it's possible to see in MRI and a lot of sophisticated technology, but in the past was possible also to dissect the specimens and to learn what happened inside of the brain. So this is very, very, very important to take in mind these things. Also not to forget the Professor Joseph Klinger, that's possible to develop the techniques about the frozen brain and techniques to dissect the white matter. That was a long time ago also. Actually, it's possible to see about this kind of the procedures and this kind of resection of the brain tumor. It's possible to see in the MRI and a lot of sophisticated technology. This is a long time ago when I was a student. We studied in Montevideo with all of professors in anatomy department, but was very useful up to now to learn a lot of things about neuroanatomy. This is one of the first paper that we published when I was a student in Argentina. We try to dissect all of the white matter tracks. Actually, it's possible to see a lot of courses that is possible to learn about the resident formation in neurosurgery. But the concept with the minimal invasive access, this was mainly to the skull base, or all the part of the structures in skull and spine, is possible to use this kind of optics in the minimal invasive manner. So we changed the concept with Professor Axel Bernetsky a long time ago, and during perhaps a small keyhole approach, for example, in retrosigmoidal craniotomy, for example, from transnasal approach, it's possible to use this kind of optic also. So the optic is introduced with a common access normally near to the retrosigmoidal, for example, if you try to resect and cerebellopontine angle tumor. And this typical a 0 degree that is possible to put in this approach or endonasal endoscope inserted into the craniotomy or in the nose. So the endoscope was placed on a stand, and it's possible to permit the bimanual dissection technique with very comfortable. And this is the first contact optic that was developed by Professor Andrea in Portugal, in Lisbon. Was an NT surgeon mainly resect a lot of laryngeal process. And here in Montevideo, I learned from also an NT surgeon that he showed to me this kind of contact optics. So we start to use in the surface of the tumors, the brain tumors, and you see there that you can use in a common manner, like a common optic with 0 degrees is 5 millimeters of diameter. And then it's possible to to put in contact of the surface, and it's possible to use in the surface of the tumor with a Steiner's common hematoxylin eosin, perhaps blue methionine. And in the last generation of contact optics, it's possible to use the fluorescence, the laser, and so on. But it's very expensive, and they are under probe here in America, in North America, I think, and in Europe. We are starting this kind of procedure. But it's very interesting, but it's, you can see all of the architecture of a tumor like in a microscope. We have three ranges of micro resection of this kind of tumor, and it's possible to test by three kind of increases. So it's very interesting to see. You see there is one of the photo, is the confocal optic of Professor D'Andrea, that normally is possible to use in this manner. You see perhaps the surface of the brain. You put perhaps in this case is one of the fluorescence that you can use, but normally you don't need this kind of fluorescence. You put normally the very cheap stainers like in histology, for example, blue methionine, the surface of the tumor. This is one example of huge glioma. And it's possible also to make the tractography, and normally in the different part of the tumor with the multimodality of neuronavigation, it's possible to put this kind of optics in the surface of the tumor. Then you can check all of the possibilities of the resection. There is one of the first images that we performed here in Montevideo 5 years ago. This is the use of blue methionine also. And you see different groups of cells with a lot of damage around the tissue, the brain tissue. And also it's possible to see and to combine with the multimodality neuronavigation. This is the image. It's like a microscope, a common microscope. You see a lot of cells normally in a malignant glioma, and in the red, all of the tracks, the white matter. But it's very interesting to see also what happened in different kind of tumors. For example, it's an example of pontine malignant glioma that we approach, but through occipital approach. We combine with tractography also. And this is how can we use this kind of optics in a combined microsurgical endoscopical approach in order to check the bed of the tumor after the resection. So you can use this optic like a common optic with a very nice image, and like the endoscopic assisted microsurgery procedures. Then if you want, this bed is stained with blue methionine or perhaps methoxylin or eosin, and you check in the histological range what happened with the limits of your resection, or what happened with the limit of the tumor. So this is part of the retrosigmoidal keyhole approach for this kind of brainstem pontine tumor. This is the image. You see the very nice image of the nerves, the fourth nerve, entorium, the upper part of the cerebellum. You see near all of the veins, the dorsal vein. This is a very nice approach. But then, this is the post-op CT. But then it's possible to check what happened with the histological architecture in this tumor. So you see very funny, very happy images, because you see the red cells running inside of the vessels. And you see a lot of blue cells like astrocytes or perhaps pericytes during the malignant glioma invasion. So it's possible to check all of the architecture with this kind of optics. We found very interesting, instrument for the tumor resection. And you see very bluish images of the cells showing the invasion of the malignant glioma around the vessels. You see there? This is very nice image. You see a very huge vessel that is invaded with along the vessel also the malignant cells with the pericytes and the cancer stem cells also that are under the basis of the residues of this kind of very aggressive tumors. If you compare with the schema, It's very interesting to see sometimes the hypoxic niches, angiogenic niches as is possible, but you see there the lymphocytes, the cancer stem cells, and the pericytes around, like the image that we saw with this kind of contact optic procedure. So it's very interesting, perhaps, to take in mind if it's possible to use this kind of technique. This is our postdoc. Also, it's possible to use in the skull base, mainly in the pituitary adenoma, that normally the diameter of the optics is permitted to introduce inside of the nose and to put under the surface of the gland, mainly to check what is gland, what is tumor, what is the border of both, to make much more safe the border of the resection. You see there, and tumor of the adenoma tumor, pituitary tumor, and then this is the different kind of procedure, or also the dispositive actually much more modern, that is possible to use actually with the use of laser and different images of fluorescence. But doesn't matter, if you have the first generation, also it's possible to use. This is the images, the use of the confocal endoscopy in pituitary adenoma. You see there at the surface, it's possible to introduce. This is after the resection of the pituitary adenoma. You stain the surface with blue methionine. And if you compare with histology, it's very, very interesting to see where is the gland, where is the normal tissue, where is the tumor. Normally we have the depth of the kind of stain is approximately 1.5 centimeters. So it's very, very important to take in mind that it's possible to use. This is different kind of techniques. You see the common hematoxylin and different kind of stainers with the very, very nice images with the last generation of confocal endoscopy dispositive. We start with these procedures in a long time ago, but actually we try to use, if it's possible, in all of the cases, mainly in malignant glioma. But we have the experience in malignant glioma, low-grade astrocytoma, pituitary adenoma also, skull-based chordoma, and normally in spinal astrocytoma also is possible to use. What is the advantage of this kind of technique? I think there's a multimodality approach to brain tumors, possible to combine with different and other procedures like for example, the multimodality neuronavigation, the use of endoscopy images at the micro-range resolution. This is different like the common neuroscopy procedures. And it's possible to check sometimes with perhaps not much more time during the operation, the safety of the resection of the tumor, mainly the borders of the resection of the tumor. Normally, it's possible to use common reactive without complications at the brain surface, without complication in infection and so on. So it's very, in this kind of approach is very useful, I think, to use. What are the disadvantages of the kind of procedure? Perhaps it's a learning curve like commonly in neuroendoscopy, but it's possible to learn because it's the heritage of another specialties like is common in neurosurgery, but we must to learn a little bit more. Coordination in the use of the 3 micro-range increases with this kind of Andrea optics is also possible, but we must to learn about that. Sometimes we obtain blurred images, but we must to improve this with the experience of the procedure. Sometimes poor enhance of cells. This is normally the disadvantage, the disadvantage of this technique. And perhaps more spend time during the resection, but not too much more time perhaps during the resection because perhaps 30 minutes more during the operation. So it's not a very long-lasting procedure or perhaps long-lasting technique if you try to do with the common neurosurgical procedure. This is one of the papers perhaps published with a lot of authors since not 2020, and they have, normally they are using a different confocal laser endomicroscopy. So we have actually also a 3D dispositive. We have a lot of very expensive, but they are under prop in different countries, and I think is the future during the resection of the brain tumor. So in summary points, confocal microscopies with fluorescence or without fluorescence normally is possible to use with Italian images that display tumor tissue architecture. The images also can be used to differentiate fluorescence or non-fluorescence caused by neuroplastic cells if you compare with another causes of blood-barrier virus disruption. Intraoperative microscope also allows for rapid intraoperative evaluation of the tissue. An improvement in microscopy can help normally improve clinical diagnostic accuracy and decision making. Mainly, I think it's very important to test what happened in the resection of the tumor. We must not forget that we are working in the micro-range resection, and normally it's possible to adapt with the supramaximal resection that is very modern actually in neurosurgery. I think it's very important to check what happened perhaps in the architecture of the tumor, and we need perhaps much more papers and studies if we can compare it's possible to improve or not perhaps the outcomes of this kind of patient. Thank you very much for your attention.
Thank you very much, Professor Alvaro Cordoba, for this very interesting presentation. We have some questions over the Q&A panel, but we are going to make discussion about after our next presentation. May I introduce Professor Abdelnaby Isa? He is Professor of Neurosurgery in Algeria, and he is past president of the Pan-Arab Neurosurgical Society, to give the second presentation in this webinar.
Thank you, Professor Nasser El-Ghandour. First, I would like to thank you for this kind invitation to be with you. And on the other hand, I congratulate you for all these great efforts you done and you continue to done for giving the young neurosurgeons all these lessons. Professor El-Ghandour.
Thank you very much, Professor Abdelnaby.
Yes.
You are going to share your screen?
Yeah, a small problem on my screen. Sorry, excuse me.
No problem, take your time.
I think I will go out. No.
Yes, you have to maybe okay. you have to close the PowerPoint and then start to try to do it again.
It's good?
No, we can't see until now. Professor Abdelnaby, you have to open the PowerPoint and then minimize, and then go back to Zoom and double click over the share screen button in the bottom of the screen. But you have to do double click.
On double click on?
Yes, on the share screen. It's green button in the bottom. It's green button down, share screen, but you have to do double click. But first of all, you have to open the PowerPoint, and then minimize. and then go back to Zoom and double click over the share screen. You're going to see one of the windows opened, the PowerPoint. Double click over the PowerPoint again. We are going to see your screen.
No, you see the PowerPoint, no?
No, still we can't see.
I go to share the screen, double
Yes.
click.
Yes, down. Can you see this?
Yeah, green, yeah.
Yes, that's right. Just double click over this button or over this icon. You are going to, it's going to open window. This window shows different, yes, now we can see. Now we can see. It's perfect. If you can maximize.
Yeah.
Okay, it's perfect now. Yes, that's very good. Thank you.
Thank you, Professor El-Ghandour, and sorry for this.
Thank you very much.
I will talk about today a surgery of low-grade glioma located in functional areas, brain mapping and awakened patient. This work was established by Professor Abdurrahman Tikanwin and myself since 10 years, and around 140 patients were operated on. The motor cortex and the speech areas, and especially Broca and Wernicke in the left hemisphere, are predisposed to glioma. For example, approximately 25% of LGG and 10% of high-grade glioma occur in the motor cortex, and most motor cortex glioma are low-grade. Why to operate LLG? First, because, and it is well established, there is a high potential risk of transformation into malignant glioma, leading ultimately to death, and in 10 years for an oligodendroglioma, and in 7 years for an astrocytoma. Second, it's always or generally, usually difficult to recognize on imaging and intraoperatively the interface tumor and healthy brain. These two examples in case of this left frontoinsular LGG, and as you can see on this T1 axial cut, you see approximately nothing. In this T2, maybe something in this area, something, and you agree for me that it is very, very difficult to operate without DTI in imaging and brain mapping intraoperatively this tumor. Also, this case of right hypocampic LGG, and you can see there is no cleavage plane, and during surgery, it will be difficult to realize a gross total removal without brain mapping. Previously, till 20, 30 years ago, to avoid postoperative complications, glioma located in functional areas benefited from check and see or wait and see, from stereotactic biopsy, or partial resection through more anterior or more posterior surgical approaches. No cortical vessel. There was a rule that no cortical vessel, as fine as it, must be coagulated to avoid this complication. When to operate? Some patients are immediately operated in case of severe neurological condition with corresponding imaging. Other patients were or are operated on accelerated tumor growth, more than 4 millimeters per year. And in these cases, it's necessary, mandatory to realize the gross total resection to avoid the regrowth. The European guidelines recommendation are today in surgery of LGG within ill-locate areas. First, maximal cytoreduction. Second, the risk-benefit ratio will be studied, preserving or even improving the quality of life. And third, increase the goal, increase the median survival. For this, pre- and intraoperative identification of functional cortical and subcortical sites for effectively and safe guidance is more than useful. What is our worry during surgery or preoperatively? The worry is how to find the balance between the optimal oncological outcome by maximizing the resection and preventing severe morbidity by loss of brain functionality. What's new since the 1940 of the last century? The first to report the use of the intraoperative mapping were Penfield and Baldry in surgery of epilepsy, and they demonstrated the mapping of motor, sensory, and language cortical areas by directly stimulating an open cortex. After Penfield, brain mapping from epilepsy to neuro-oncologic field, the pioneers, the experts were and are till today Hodgman, who introduced the Hodgman cortical stimulator, Michael Berger in the University of California, and Hugues Dufaux in France demonstrate the exponential increase of the usefulness of the brain mapping. Some words about the cerebral plasticity to understand better the usefulness of brain mapping. Brain is not a physiologically static organ, and contrary to common ideas, brain functions are not confined to fixed locations. There are changes in neural pathways and synapses induced by change, behavior, environment, and neural processes. The cerebral plasticity or neuroplasticity is this ability for brain functional reshaping, the biological, chemical, and physical capacity for the brain to reorganize its structure and function. Statement: LGG is more frequent within the eloquent areas, considered classically as inoperable, with clinically no or only mild neurological disturbance, or with symptoms as seizures. LGG, LGG slowing growing lesions migrates along the white matter pathways. Brain reorganization can take place before and after surgery. And in the case of glioma, plasticity can occur first preoperatively and then postoperatively, with this reorganization mainly prompted by surgery. Adaptation terms: when the tumor is in the eloquent area and when the function compensation is in the remote areas, other remote areas, real total resection is possible with a slight and very transient deficit which disappears some days, 1 week or 2 weeks after surgery. The tumor within eloquent area, but with function redistributed around the tumor, good resection is possible. And here also, certain transient deficit can be observed, but recovery within few weeks to few months. And finally, the infiltrative LGG without destruction. Consequence, the function still persists within the tumor. Resection, subtotal resection without inducing deficit is impossible. The challenge: to know before surgery. Through the functional neuroimaging preoperatively, through the intraoperative electrostimulation in real time, to know where are the eloquent areas. Here, to remember you, the main eloquent areas, here the motor cortex in red, the primary visual cortex in the posterior part of the hemisphere, the secondary visual cortex also here, 37, 18, the primary auditory cortex in 41 here, and 42 here, and the Broca's area, the 44 and 45 areas in blue and in red. Left inferior frontal gyrus, temporal gyrus are the areas of the language processes of the brain. Here, as I said, the Broca areas, 45, and here the Wernicke areas located in the angular gyrus, middle temporal gyrus, supramarginalis gyrus. Imaging modalities. The aim is to identify cortical and subcortical areas of eloquence and their relationship to the lesion. Preoperative imaging, standard MRI, FLAIR MRI, spectroscopy, PET scan, functional MRI, and DTI. Intraoperative MRI, when it is available, the ultrasound and the fluorescence. We should consider glioma surgery as brain networks surgery. And here, in this view, panel E and C, 8 major cerebral white matter tracts, and you can see the cortical spinal tract in dark blue here. here, the forceps major here in the posterior part, and the uncinate fasciculus in yellow in this U shape here. In this view, you can distinguish the EFOF here in orange, the inferior longitudinal fasciculus here, and the anterior superior longitudinal fasciculus in green here. Functional neuroimaging, functional MRI, PET scan, DTI, as I said. What is DTI? Imaging techniques based on the concept of anisotropic water diffusion in myelinated fibers, which enable 3D reconstruction and visualization of white matter tracts and provide information about the relationship of these tracts to the tumor mass. For Xiong Xiao in January 2021, understanding the anatomical relationship between the tumor and tracts is helpful to determine the approach, and many studies have shown that DTI is a highly valuable tool in preoperative surgical planning. For him and his series, more than 1/3 of the approaches were adjusted after taking the DTI results. You can see here this axial cut MRI T1, the tumor, and you can see on this DTI the tumor here, the superior frontal pathway, and the corona radiata on this sagittal view. You can see here the pyramidal tract with the tumor. Some other images in color of DTI. And here, this tumor, you can see on this T1 with gadolinium. Here you can see, and you can see the tractography, and you can see the pyramidal tract compressed by the tumor. Resection of interaxial lesions involving the temporal, parietal, or occipital lobe may result in permanent visual field due to the injury of the optic radiation, the visual cortex, or both pathways. PET scan, here you can see an increasing of the CBF in the tumor after injection of O15 or fluor 18. Magnetoencephalography and transcranial magnetic stimulation are used since some years, and they are not imaging techniques. Intracarotid amytal or WADO test is this utilization of the WADA test, but its use has decreased since the advent of functional MRI. And the principle is the WADA test caused during few minutes contralateral hemiparesis and allow the neurosurgeons to test language and memory. His use is principally in epilepsy surgery. Here, Jun Wada, in the operating room, performing a carotid artery puncture for injection of sodium amytal. The preoperative study of imaging of the patient include also the neuropsychological assessment. And also in the operating room, it's crucial to have with us the speech therapist. Before the surgery, the semantic memory test, pyramid palms tree test, PPTT, measures the capacity to access detailed semantic information about words and pictures. Now we'll talk about the intraoperative stimulation mapping. We are in the operative room and we use electrocortical mapping, but also subcortical stimulation. Here, the Hodgman stimulator, which don't cause any damage for the brain. The responses are reproducible, and the goal is to have a motor map, sensitive map, and speech mapping of the cortex. The early surgery has as goal maximizing the extent of resection and to distinguish with the brain mapping the interface between tumor tissue and the surrounding brain. Surgery is performed under asleep-awake sleep anesthesia. The intraoperative identification and preservation of visual pathways requires the patient to be awake and fully cooperative. Here, the environment, intraoperative functional monitoring by speech therapist, intraoperative adapted tasks inferior to 4 seconds and selected according to the quality of life of the patient, the lesional site, the neuropsychological assessment, and the preoperative functional neuroimaging. Here, the patient, usually in the right lateral decubitus for the left located lesions, and we should pay attention to support points such as iliac crest and armpits, and allow ourselves the possibility to perform massages if numbness in the upper or the lower limbs. Skin infiltration in this slide and the cutaneous flap. Here, a wide bone flap is necessary for this surgery. Here, the opening of the dura in X, and this circle corresponds to the infiltration dura. Here, the middle meningeal artery, the dural infiltration, and the dural opening in X. First, we use the ultrasound intraoperatively to delineate the tumor. We haven't the intraoperative MRI, and we found that the intraoperative ultrasound is very useful and inexpensive, widely available, and provides real-time visualization of tumor and its delimitation. Here, the tumor. The boundaries of the tumor are determined by this letter A, F, C, D, G. By this letter also, we have the limits of the tumor, and here we start the brain mapping with, in 1, 2, 3, the primary cortex, in 4, here, the motor cortex, and in 45, the Broca's area. Practical stimulation methods, we should stimulate the whole of the exposed cortical area, every 5 millimeter square. We should stimulate every site at least 3 times, but never stimulate the same cortical area twice successively. Always carry out a checking test without stimulation between 2 stimulations. Always keep surfaces to be stimulated barely wet, and in the event of seizure, we should irrigate with cold serum and do not re-stimulate immediately afterwards. Stimulation-induced seizures, as I said, they occur in 15 to 10% of cases. We should humidify lightly the surface, use cold ringer, and another measure is the use of Rivotril. Here, delineation of the tumor boundaries with the ultrasound, and here the letters for delineation, and here the number for motor cortex and for motor cortex. Some cases, a left oligodendroglioma grade 3 in a right-handed patient. Here you can see the central sulcus, but the pre-central sulcus here is only little visible. The surgery, the central sulcus here, the precentral sulcus here, and the tumor delineated by the letters A, B, C, D, and E. The tumor is here. And the MRI post-operatively, you can see it's a subtotal removal. Maybe there is a small remnant here. Another case with delineation of the tumor by the letters A, F, E, and the numbers 1, 2, 3, 4 for the eloquent areas. Tumoral resection and subcortical mapping. In some cases, subcortical mapping is needed and useful to perform a gross total resection. Here, the limits of the tumor, E, F, A, B, C, and here the eloquent areas 6, 44, 46. And here the operative field. can see in this slide, on the right side here, with this double star corresponds to the post-central sulcus on this Earth hemisphere. And this star, white star, to the central sulcus, which is absent on the side of the tumor. Preoperatively, on this sagittal view, the tumor, the DTI, the tumor, the glioma is here, the pyramidal tract, and the other spinothalamic and thalamocortical pathways are compressed but not invaded. Postoperatively, and reoperation of the sulcus, central sulcus here, and the post-central sulcus here. Data of the stimulation, on the whole, data of the stimulation are more useful than those of tracking. In conclusion, we can assert that usefulness is now demonstrated, and the awake patient, the 2D or 3D intraoperative ultrasound with or without neuronavigation, but with DTI, are useful and lead to gross total resection of LGG of low-grade glioma. And we don't forget that LGG is not a benign tumor, is not a benign tumor, because some years after, if it is not operated, the LGG will be a high GG, a high-grade glioma. It is a precancerous lesion. We should to maximize the resection, minimizing in the same time the morbidity. Realizing complete planning requires to associate several making techniques preoperative and intraoperatively in order to optimize the ratio benefits of tumor extensive resection to the risk to induce permanent deficits. And I thank you.
Thank you very much, Professor Abdelnaby Ben Isa. Another great presentation. We enjoyed listening to your talk, actually. Now we have some discussion before we proceed to our third speaker. I think now we are glad that Professor Mahmoud Qureshi, President of the Continental Association of Neurosurgical Societies, the CANS, he already joined the panel. Mahmoud, are you here?
Yes, I am, Nasser. It's a pleasure.
Thank you for joining, and I know that it's a pleasure to have you, and we are honored, really.
Thank you very much, Nasser. It's always a privilege to join the webinars that you have so effectively organized on behalf of the Egyptian Society and on behalf of CANS. And you have done a marvelous job, and it's such a pleasure to see Abdelnaby Ben Isa after a long time, thanks to your efforts. Such a pleasure to see you, Abdelnaby, and also to see our friend Alvaro Cordova. I'm looking forward to seeing Keki after such a long time, and listening to Morsi's lecture as well. So thank you once again. It's a great pleasure to be part of this webinar. I shall need to leave because I will be joining Wahabi's webinar after this one, but I do believe we have some time, so I'll have the pleasure of listening to Professor Keki Turel and Al-Morsi's lectures. Thank you again, Nasser. You're doing a wonderful job on behalf of CAMS.
And thank you very much, Professor Mahmoud Khorashi. I think we have questions over the panel. I think there is a question for Professor Alvaro from Mariam Ghanem. She is from Egypt. Let me just check if she's available and she can speak directly. Mariam, can you hear me? Yes, just 1 second. Allow to. Mariam, can you hear my voice?
Yes, Dr. Nasser, I hear
Okay.
you. Yes, yes.
Please
Dr.
make
Nasser,
your
I hear you
discussion.
clearly.
Introduce yourself, then start to say your comments. Mariam, she is from Egypt.
Hello, Dr. Nasser, and thank you very much for the serial great webinar. Very beneficial webinars. Thank you, my professors, for this great presentation. I have a question for the first presentation. What I understand that a confocal endoscopy is a real-time histological analysis over than the traditional endoscopy. Is it right?
Mariam, can you raise your voice, please, and say the question again?
What I understand from the first presentation that a confocal endoscopy provides a real-time histological analysis for the tissues while we perform the surgery, and this is a great benefit superior to the traditional endoscopy. Is this right? Or
Hi, Marian. I am Alvaro Cordova. Nice to talk with you and nice to meet you. I think, Marian, in perhaps in one aspect is superior because with endoscopy, traditional endoscopy, it's possible to use like a common scope. It's possible to explore all of the details in anatomy inside the brain, inside the skull, in the spine, and so on. But if you use this confocal endoscopy, is very important because it's possible to check the histologic situation of the tumor. So so in only one tool is possible to use like a common endoscopy, a common endoscope, and a common microscope inside. So actually, if you search, a lot of companies under the develop of laser, 3D, and so on, and very amazing images of the architecture of the tumor. So if you combine with another things, I think it's very useful to use. It's possible to use. So I think it's a little bit better like the common endoscopy.
Thank you, Professor Cordoba, for this answer. Mariam, I think you have another question. Okay, I will read it from the Q&A panel. She's asking, I think, Professor Abdelnabi, if patient presented with recurrent fits, in such case, contraindications. Yes. Mariam, are you here?
Yes, Dr. Nasser, I am here.
Say your question directly, please.
If a patient presented preoperative with a recurrent attacks of fits and not controlled with medical treatment, in such case, is it suitable for a vitrectomy, or how can we deal if develop fits intraoperative while doing a vitrectomy?
I don't understand what is the question. The question.
For Professor Abdelnabi.
Oh, okay, perfect.
Yes, thank you, Dr. Mariam Ghanem. If I understand, your question is if the patient presents fits, recurrent fits, how to do during or for the surgery?
Yes.
Yes. The seizures should be treated medically before surgery. And today we have many medicines, many to treat the patient who suffered from epilepsy, and to have a patient 1 day, 2 days before surgery without seizures. Now, if your patient during surgery presents seizures, and as I said, the best mean to stop these fits, these seizures, is to irrigate the surface of the brain with cold saline serum,
Yes.
and to wait the necessary time.
Yes.
And don't re-stimulate some seconds or some minutes after. You have to wait, and usually you can continue the surgery without difficulties.
Yes. Continuous irrigation with cold saline. You
نعم.
can do this. Continuous irrigation with cold saline to control fits.
والله I don't understand what you do.
Continuous, we do irrigation with cold saline to control fits.
Yeah.
Yes. Thank you.
Thank you,
Dr.
Mariam.
Abdel-Nabi.
Thank you very much. Now it's time to move to our next presentation. Now I am honored. Anybody would like to make any other comments? Okay. Now it's time to move our next presentation. I'm honored and have the pleasure to introduce Professor Kiki Torel. He is my deep friend. He's my brother. He's working very active. He's organizing many activities all through the year, either webinars or in-person meeting. We are proud really to have Professor Kiki Torel with us today. And he created a new specialty in neurosurgery, which is complications in neurosurgery. And right now he is the chairman of the Complication in Neurosurgery Committee of the World Federation of Neurosurgical Societies. Thank you very much, Professor Kiki Torel. You are always a friend to all Egyptians and to all Africans. We are honored to have you with us today. Thank you.
Thank you very much, my dear friend Nasser, and Mohammed, and Alvaro, and Meleza, everybody. Thank you very much. It's indeed really a great pleasure for me to be here once again between my friends in Africa and myself. Thank you very much. So we say namaste, traditionally. So my soul honors your soul. I honor the place of you when the entire universe starts. So we are one. In short, we are all one.
Yes.
And especially in times of this crisis, the whole world must unite to fight this for our own good.
Yes.
Let me talk about surgery for gliomas in eloquent areas of the brain. Some do's and some don'ts. So, as we know, having made significant progress in surgery of benign lesions of the brain, like acoustics and meningiomas and pituitary tumors,
excuse me, we couldn't see your screen.
I will come. My screen is right here. This is my slide going on.
Okay.
Management of gliomas still remains an unconquered, just move this out, an unconquered territory. So, on one hand, there is a challenge. On the other hand, there is a hope. So let's look at the challenge and let's get on to the hopeful aspects of gliomas. Why is it not going? We were talking about eloquent areas. Now, the brain for which other structures cannot take up function in the event of an injury is called eloquent. But eloquence is an important concept for procedures when you are working within the brain, especially for things like epilepsy, tumor resection, and AVMs. But remember, working in eloquent cortex, the key is functionality and lack of redundancy. That means there's nothing redundant in the brain. If you look at the brain model, there is nothing that is not eloquent. Every aspect of the brain is having some important function. We should not restrict our eloquence to motor, sensory, and speech area or visual area alone. There are so many fine functions which are important for the day-to-day functioning of an individual, and I will gradually come to them. And therefore, we require close monitoring during surgery of the brain in order to ensure maximal safe removal of the disease. So eloquent areas are all over the brain, including the central brain, the thalamus, the midbrain pons, the cerebellum. All these areas are eloquent.
Kiki,
Sorry,
please, we couldn't see your screen.
My screen, but I'm
Is,
going
is
on
it working? Is it
You can
working
see
in
my
your
PPT? You
in your
cannot see my
PC?
PPT?
Yeah. Can you reshare your screen, please, Professor
Okay.
Kiki?
All right. Is it all right? Is the slide visible?
Yes, yes, now it's perfect.
All right. So shall I go back to the earlier slides?
Yes, please.
Okay. All right. So as I said, there has been significant progress in benign lesions, but management of gliomas still remains an unconquered territory. There is a challenge, and there is also hope. So eloquent brain is a brain for which other structures cannot take up function in the event of an injury. And it's an important concept for working for pathologies like epilepsy, tumor resection, and AVMs. But working in the eloquent cortex, the key is functionality and lack of redundancy. If you look at this brain picture, when we talk about eloquence, we talk about motor, sensory, and speech functions. But you must remember there are many other areas like sound, like hearing, like naming objects, like planning, like imagination, and language areas and vision. So whole brain, in my opinion, is actually eloquent, and therefore it requires close monitoring during surgery in order to ensure maximal safe removal of the disease. So the eloquence does not remain only to those areas, also to the central areas of the brain, thalamus, brainstem, cerebellum. And now you can see how many important areas are there in the brain. So nothing is non-eloquent. Theoretically, every part of the brain is eloquent and nothing is truly redundant. But we have to talk now about mainly the eloquent areas concerning the motor sensory functions and speech, and tumors that we are talking about are primary gliomas. I'm not going to touch other areas as my subject is restricted to gliomas of the brain. Low-grade gliomas are frequently located within eloquent areas. As you can see in this picture, supplementary motor area 30%, insula 25%, primary sensory somato area 9%, primary motor area 6%, Broca's area 15%, and language areas 15%. So totally, language areas in 50% overall of all these patients where low-grade gliomas are frequently located. Can you see my slides now?
Yes.
Okay. So the European guidelines say that surgical resection represents the first treatment option with a goal to maximally resect the tumor mass whenever possible, whilst minimizing post-operative morbidity. And same with the NCCN, National Comprehensive Cancer Network, supports surgery as the initial intervention for LGGs. Just check my time. When we are operating around eloquent areas, the preoperative assessment is very important. And preoperative means clinical and psychosocial on one hand, and radiological. Let me first talk about clinical and psychosocial. Remember, psychological assessment is not a luxury. It is very important. Cognitive deficit, despite a normal life, can occur in 80% of patients. But that requires to be evaluated by a psychologist, neuropsychologist. So that means executive functions like increased reaction time, working memory, attention, emotion, social cognition, all these are so important. And it's not just enough to be able to move your hand and leg or to be able to speak. Similarly, radiological preoperative mapping is important by the tumor protocol of MRI. And then anatomical location of the tumor and its relationship with the eloquent areas, looking at the functional MRI to see the functions on the MRI, relationship with eloquent areas and their connections, and tractography to determine to find out where the important tracts are compressed or infiltrated, so that we can find a route of entry which has the least impact on the fiber tracts and can reach our tumor area very safely. For example, this farmer, 35-year-old young man, presented with giddiness in August 2016 with headache. And the pathologist, neuroradiologist, just made a diagnosis based on this alone, as this is likely to be a subacute infarct or a possible encephalitis. Now you see, if you are ever in doubt, and if you want to make a diagnosis, you do not just make a diagnosis and ask the patient to go away. If you are in doubt, you have to ask the patient to come back in a couple of months. And if you are sure that the patient is intelligent enough or educated enough to come, if he is not, then you have to do something to prevent something like this happening. So after 16 months, this poor farmer comes with severe epilepsy and functional disturbances, and you can see a mass lesion in the right temporal lobe extending everywhere. And what does it happen to me? It turns out to be eventually, when the craniotomy is done after 16 months of the first MRI, it's a diagnostic anaplastic grade 3 astrocytoma. We have missed a bus. So anatomical location of the tumor means relation of the tumor with the eloquent areas. And this is premotor area lesion. Here you can see that the speech area has been displaced. It's in yellow. The tumor is in red and black. And functional MRI, again, the tumor has displaced these supplementary motor area in the front and the motor area behind. And the tumor is very safely lodged, but abutting against both these areas. So therefore, you have to find a safe trajectory to reach this tumor by avoiding all these supplementary motor cortex, primary motor cortex, and then which area would you choose? And therefore, the trajectory should be avoiding these eloquent fibers or eloquent cortex. FMRI will not show focal cortical activation in as many as 20% of patients with brain tumors. And the concordance between fMRI and intraoperative cortical stimulation ranges between 60 to 100%. It's a very big concordance. Range of accuracy is 55 to 15 millimeters. And mind you, these gliomas are not homogeneous tumors, they are heterogeneous tumor types. The next point is DTI. Now we can see the tumor having displaced fiber tracts. This tumor has displaced the motor area, speech area. But when you talk about functional MRI and DTI tractography, there is no, as far as fMRI is concerned, there is no differentiation between critical versus compensable areas. 35 to 40% of sensitivity for language is missed by functional MRI. Whereas tractography is an anatomical tracking system. It does not do functional mapping of the fibers. So again, the reliability is not 100%, 82% of reliability as far as language tracks are concerned. So you have to be careful when you evaluate functional MRI and tractography. The current trend is combining functional imaging modalities with frameless stereotactic techniques, real-time functional imaging in the operation room, and becoming more widely available. I'll show you some cases, examples. Young boy of 18, he saw me in 2013 with weakness on the left side, gripping difficulty, diplopia, facial weakness, headache, imbalance. And this is this young man who came to my office. And this is the MRI. It shows a large lesion in the subthalamic area and the midbrain area, as you see over here in various slices of the MRI. We did the DTI. Mind you, this DTI was very primitive. This was more than 8 or 9 years ago. And you can see that fiber tracts are displaced laterally by this tumor. Originally, my aim was to go subtemporally directly straight by a straight line, short distance into this. But when I saw these fiber tracts, I realized that I may be endangering the motor areas. And therefore, what is the least eloquent fiber tracts? And I saw this was the least eloquent area. And I decided to go by a longer route, by going supracerebellar, midline approach, straight into the tumor from a long distance from the posterior fossa. So this is the patient's posterior fossa. He's prone, and I opened the dura, coagulated his cerebellar veins, retracted the cerebellum, and I'm straight on the tentorium and down onto the midbrain. You can see me directly. There is no eloquent area on the way. I'm straight into the midbrain tumor area, and I'm already dissecting the tumor very carefully. I'm able to get under direct vision. It may be 7 to 9 centimeters deep from my surface, but it's very safe. I'm not endangering any fiber tracts. And this is the way I was able to take out almost all of the tumor. It turned out to be pilocytic astrocytoma. Look at the preoperative axial pictures and the post-op, pre-op coronal and post-op and sagittal. And this was only 4 days after surgery in February 2013. This patient came immediately post-operative. You can see his functions are intact. I have not harmed his optical pathways. His tectum is intact, and his gait also is very good. He still has to recover. It's only 4 days after surgery, just before discharge. And now he has come to me after 8 years. He has been coming regularly. I just scanned him because Nasser told me I have to speak on this subject. So I got him over and tracked, and I'm very happy to see that there is practically no more tumor growth. This is some calcification, which the MRI people said, I don't know why this is there, but patient is intact. You can see him clinically now. What happened? Just single click. Yeah. Good eye movements. He's become a big boy now and quite normal. No incoordination, and gait is absolutely normal. So, take-home messages. The preoperative MRI suggested that I might do a subtemporal route, but then after seeing the DTI, I changed my opinion and I went by a completely different route. This is a 45-year-old woman, seizures, left arm and face, weakness, left grip, a very affluent woman staying in a good society, but she allowed herself to for 10 months, and there was a we already had a nice talk on this, but you can see the patient is already on neuronavigation, and but you can see the hemiplegia. The leg too is very weak.
Now the left leg, raise it up and down.
She can hardly hold it.
And
It
move your
drops
foot
down.
also up and down. Bend the knee. Yeah,
Cannot.
bend it
There is
completely in.
significant weakness of the knee and significant weakness of the foot also. Okay, so here we are. Wide excision. I prefer to have a wide so that I can do my mapping, I can do my cortical stimulation or whatever I want, and navigation. And here, staying strictly inside the tumor, not disturbing the neighboring brain area. And whilst I'm operating, you can see in the inset, my anesthetist is constantly monitoring so that we have no more motor deficit. The tumor is excisable completely. There's no point in trying to do any hemostasis at the beginning. Just get rid of the whole tumor. Go on with the irrigation. She's in a recumbent position. And post-operatively, you can see she's lifting up the hand on the operation table still.
Now the leg.
And the leg,
Fantastic.
which was so weak before, is lifting up. There was a foot drop, and the foot is now,
I believe you also move
even
your feet and toes.
intraoperatively itself, you can see the foot moving.
Wonderful. Look at that. You're not doing it before.
Excellent.
Fantastic.
So you see, immediate relief of pressure symptoms and immediate relief of motor fiber tracts. So
You succeeded.
gone are those days when we said brain tumor surgery might produce more insult to the brain. Here we have, and the patient much later has sent me this video from her home, and she's very happy and doing well. Okay. When it comes to decision making, awake or non-awake, not moving. So we can do awake intraoperative mapping or non-awake with intraoperative mapping. Now, awake surgery already been discussed in previous lectures on brain tumor or awake surgery. Non-awake is done with intraoperative mapping in extraaxial tumors, the tumors which are relatively non-eloquent, in non-cooperative patients like children, and anesthetic contraindications for awake surgery. So when you're doing non-awake and intraoperative monitoring, you already saw that you have Ogerman's direct electric cortical stimulation. The advantage is that you can detect essential areas and epicenters. Cortical subcortical mapping is very accurate. The accuracy is less than 5 millimeters, reliable, online, and safe. So I heard Dr. Dufau many times, and I quite like this gentleman from France. He limits his resection to cortical and subfunctional structures with no margins. And he says functional mapping is the key. He does not do image-guided resection, no neuronavigation, no DTI, no fMRI, no intraoperative MRI, not even a microscope, and no EEG control. He just does mapping, functional mapping, and takes the whole tumor out simply by functional mapping. He does this macroscopically, without a microscope, and he tells me that he does his operations mostly in a couple of hours, 2 hours. And most of his patients have no neurological deficit. Well, it is open to discussion and open to some kind of controversy, but he has more than 1,000 such cases. Now, I'm showing you a patient whom I would have liked to do with awake, but could not do it. Medical student, 2007, she saw me, generalized headache and vomiting for 3 weeks. And when she was first having seizures, this is the scan done. And it shows a focal lesion here. She was given anti-epileptics and forgotten. Nothing was done for the next 16 years. They all forgot, anti-epileptics were stopped, no more scans done in the interim period. And then when she came to me, she had seizures. And this is what she came with. She's neurologically quite intact. So I thought she would be a good case for awake surgery. Look at the lesion. She was not investigated, and after 14 years, this lesion is all over the place, motor area, speech area. And I would have liked to give, but she was scared, she was nervous. She said, I don't want awake surgery. So I had to operate on her. This was DTI. I had to operate on her in a general anesthesia. So I go by classical microsurgical technique. She had a cystic lesion. I could aspirate a lot of CSF from the tumor fluid, open up the sulcus, typical microsurgical operation. You can see this jellyfish-like tumor, very solid, gray, very distinct from the neighboring brain. And this is a clearly separable, nicely separable from the surrounding area. This is 2007. I'm using CUSA without any fear because I can see the tumor very clearly separable from the neighboring brain. And I go on quickly. After having done suprasylvian, I now go infrasylvian. I skip the motor area, skip the Broca's area, again go by the infrasylvian route and catch the same tumor residue from below. And as I'm doing it, I'm getting the remaining residual tumor. It's a large craniotomy, large exposure, supra-infrasylvian exposure, and complete tumor removal. And this is the area. This is a part of the brain that you see post-operative.
Thank you very much, Professor Kiki Torel. Great presentation, as all your presentations. We will have a discussion at the end of this webinar.
Yeah, it's okay.
But now I can see some comments over the chat panel. But now we proceed to our last speaker, Professor Ahmad Ali Morsi. He is consultant of neurosurgery at the Qazik University in Egypt, and he is one of the eminent functional neurosurgeons in Egypt, Africa, and the Middle East. Ahmad, are you ready?
I have not finished my presentation.
Ah, Kiki, you didn't finish?
Oh, it just went off. The internet went off for some time.
Ah, we are sorry about that. Thank you very much, Ahmad. We go back to Professor Kiki Torel.
I have
because
Yes,
the
sure.
PowerPoint was finished and we couldn't hear any voice in the last two slides.
To share with you.
Yes, yes, please go ahead, Kiki.
I'm
Oh,
so
yes,
sorry.
sure.
I hope Dr. Morsi does not mind.
No, of course, we are
Yeah,
enjoying
sure.
your presentation.
Yeah, we are very enjoying your presentation. Thanks, Prof. Kiki.
Thank you. So, come and see it then. Here. Now over here. Yeah.
Yes, now we can see.
Yeah, this was last slide. After that, we'll come to the next one, and now the next one. Yeah, okay. All right, so we combined this intraoperative navigation using fusion of DTI, and this is the clinical patient, and you already saw that. And that is my intraoperative navigation. And we managed to get this tumor excision complete using intraoperative DTI. Now, this was the same lady. Now, the problem with this patient was that we planned to do an awake surgery on her. But just before the awake surgery, she had a massive seizure. And because of the seizure, we had to give her some sedation and she had to be given anti-epileptic drugs. As she woke up from the epileptic effect, she became uncontrollable. And it was uncontrollable. We could not continue with awake surgery. We had to stop this procedure and we had to give her general anesthetic. And then we operated on her. And this is the post-operative scan on the second day after surgery. Shows us complete tumor removal. And that is 2 days after surgery. And neurologically quite intact. This is a scan done 10 months post-operative and shows no tumor return. You have put it in the wrong place. Now, ascertain the goal of surgery is the most important part. Now consider the age and general condition of the patient, extent of resection, whether we should do maximal safe resection or just debulking or decompression. Maximal safe resection is ideal because it eliminates the sampling errors, provides critical tissue for confirming the diagnosis, because as you know, the same glioma can have different subtypes. In the same tumor, you can have from grade 1 to grade 4. Also, maximal safe resection impacts seizure control and therefore improves quality of life, reduces symptoms and signs from mass effect, and provides hope for the patient and their families. So ideally, we would do a lobectomy if there's a diffuse frontal glioma like this, and that's the post-operative. Or you may do a lesionectomy so that we can have a complete lesion removal, but we do not remove this area because this is flare area. Maybe we want to preserve her visual fibers. Here is a near total resection, 99% total removal. But in some instances, we are forced to do a subtotal removal, and here just a partial removal. I won't go into details why that was done, but these are the different grades of excision. And here we come to the third extent of resection, which is just decompression. Very extensive glioblastoma. Very difficult to identify different areas of the brain, and we can just do a partial resection or a biopsy and decompress. Or another patient with a butterfly glioma, patient insisted, I would not have liked to operate on him, but they insisted that something needs to be done for him. So I said, we will just do a biopsy and do a wide bifrontal decompression and nothing more than that. Therefore, you must know your limitations when it comes to operating in eloquent areas. Size of craniotomy, it can be small or moderate if you are going transsulcal. It can be large if the brain is edematous, where intraoperative mapping is of course to be done, and then you of course require a larger surface of the brain. And for insular gliomas, which are located posteriorly, you need to have the full exposure of the Sylvan fissure, and therefore you have to have a large craniotomy. Now, if you're going transsulcal, as in this case, you just need a circle approach and a small craniotomy. But if the brain is edematous like this, just get rid of this. Then you need to have a large craniotomy and also removal of bone flap, as you see over here. And sometimes a bilateral removal of the bone flap. Intraoperative mapping is done. We require larger bone flap removal, a larger craniotomy. And for insular gliomas, which are extensive, then the craniotomy has to allow the full exposure of Sylvan fissure. As you can see here, 25-year-old software engineer just had a blackout, and you can see the size of the lesion. Insular gliomas quite often present with just a seizure. And when you really scan the patients, you can see the middle cerebral artery extensively involved from both sides. DTI shows all fiber tracts displaced. So I do our largest craniotomy, expose the Sylvan fissure, widely open, and the patient is awake. We are talking to him. Sorry? Yeah, we are talking about cricket, and he's listening to the cricket match whilst we are operating on him. We are talking about some cricket idols. Cricket is like a religion in India. And so we are talking about cricket whilst I'm operating on him. We are discussing mathematics. We are discussing his likes and dislikes and his cognition and so many other aspects whilst we are operating. And what am I doing? I'm locating the tumor between the branches of the middle cerebral artery, what I call as skeletonizing the MCA. So this is more a surgery of the middle cerebral artery rather than a glioma surgery. And we remove all this glioma between branches of the middle cerebral and leave nothing inside. The short perforators which go from these large branches into the tumor are coagulated and cut, but these are the only vessels which are cut. We allow the long perforators to go away. Long vessels are not touched. They are allowed to go, and you can see the massive amount of tumor coming out by working between blood vessels, between the branches of MCA. And you see wide. So we are talking constantly to the patient. My assistants are discussing other things with the patient. We have prepared the patient with a proper questionnaire, and the tumor is all removed, all completely excised, and it's time for closure. Postoperative, immediate postoperative. Conscious weighing commands, moving all limbs. The left-sided tumor. All right, he's doing well. And this is postoperative scan. Pre-op, post-op. This is just a tumor bed, blood in the tumor bed, complete tumor removal. The next point is approach. Tumors in eloquent region are approached via neighboring or non-eloquent sulcus. It may be a longer route, and you can do transsulcal. You can begin with tumor forceps, telomesser, CUSA may be employed, but you must remove it only for the core. Do not shave the periphery. For example, this patient, recurrent seizures, young computer engineer, fMRI, DTI, MRI, MR spectroscopy. This operation was done by me 2005, I think.
Use it just now.
We do it under awake now. Left side. Complete tumor removal. I won't go into the details because time is short. And this is immediate postoperative. Tumor removal is over here. Next day, postoperative scan because patient is awake. We have nothing, only one intravenous line. And he can go home the next day.
And what are things you saw in the video?
so good. But if eloquent cortex is involved, you may go through it directly because the cortex is already gone through it. What are the intraoperative aids?
Huh?
You have USG, you have intraoperative MRI, brain suite, 5-ALA, sodium fluorescein. Lesion in the insula, very convenient to map by ultrasound. But sometimes you may not want to operate. Why? Because there is a functional risk of surgery. And when there is a functional risk, what do? The solution is mapping techniques. Goals are to find lesion and resect it, maintain function after resection, avoid permanent deficit. Of course, there are questions about patient selection. When is it indicated? What are the different techniques that are available? How should you use this information? And the limitations and pitfalls. So we have seen that direct cortical stimulation. We have seen advantages of detailed mapping, cortex and white matter, brain mapping of SSCP, intraoperative MRI with DTI and brain suite, use of 5-ALA. You can see the red tumor. And you can use sodium fluorescein, which is much cheaper now. Intratumoral debulking. We had this very, very vascular tumor in the frontal region abutting against the motor cortex. We did an operation exactly through the, just like a typical microsurgical operation, through the sulcus. I want to rapid it, make it fast. So I will go very quickly through this. There's a lot of bleeding inside. So at some stage we had to stop. I don't want to show you the video, but this is the post-operative scan. Most of the tumor is still inside, but we had to stop prematurely because of extensive bleeding. Now what do? It's a young boy. The tumor came out to be GBM, glioblastoma. I spoke to the mother. The father was not available. He was already suffering from cancer. I spoke to the mother. She said, doctor, do whatever you want, but get the tumor out. So I said, I planned a new strategy. And what is that? Our normal neurosurgical strategy is going through the tumor, which is what I did. But now I said, I will not go through the tumor. I'll go around the tumor. And this is a way I re-explored. Let's keep on going fast forward. It's going fast forward. That's going fast forward. And I go around the white fibers, around the tumor, and we completely remove the tumor. This is a post-operative scan. So take the chance of going around the tumor in these kind of cases instead of going through the tumor. And finally, preserving blood vessels. There could be veins and there could be arteries. Cortical veins, sylvian veins. Sylvian fissure is frequently opened in these kind of patients, especially for insular glioma. And I don't want to show you because you all know how to open it. And there's an oligoastrocytoma, grade 2, which we removed completely. This was the lobectomy done by me. But she came 6 years after this lobectomy with a seizure. And when I did an MRI, this was a new tumor coming from the posterior margin of the previously excised tumor, abutting the motor cortex. So I said, this tumor has to be completely removed, and it's an oligoastrocytoma. And unfortunately, we had not given her radiation or chemotherapy, but she survived 6 years completely free of tumor, and then came this tumor. So we did awake surgery here. And why I'm showing this to you is because we had to do an extension of the previous craniotomy. It was abutting against the motor cortex, and we had to be careful preserving the motor area. And dura is infiltrated, and we go into the tumor, identify the tumor. The tumor is, as we saw on the scan, completely separate from the, why is it not moving? Tumor is completely separate from the motor sulcus. This is a sulcus separating the motor area from the tumor, premotor sulcus. So I'm very gradually retracting the tumor away, identifying the blood vessels. These vessels are supplying the motor area. Some of these branches may be supplying the tumor, but most of these vessels are vital areas, our vital vessels cannot be sacrificed. Very carefully. Now, this is 6 years after the previous surgery. And you can see me dissecting the gray tumor with my left hand, identifying the tiny little perforators going. We tease them out, we separate them out, and only coagulate those tiny vessels which are getting into the tumor. Coagulate and section, and preserve everything else. So I managed to get the whole tumor separated now from the cortex, and now I am in the subcortex. Again, doing the same procedure. Patient is awake, patient is cooperating, and this is the way I managed to get the entire tumor out completely without damaging, keeping the patient awake. Fast. So tumorous gyrus, as we saw, can be dissected from the non-tumorous gyrus, but with the white fibers, you have to be careful. Be very careful when you are using CUSA, as far as possible. Avoid it. And then be careful about the en passage arteries. So this patient is immediate post-operative after awake surgery. And quite all right. And this is the post-operative scan. Complete removal of that small fragment which was stuck over here. So I will conclude my talk by saying that gliomas in and around ileoquoid areas pose a unique challenge wherein one has to balance between achieving maximal resection and preserving the patient's neurology without harming the patient. Accurate pre-op imaging and correct operative decisions, awake, non-awake surgery with intraoperative neuromonitoring and brain mapping, and use of various intraoperative aids are very vital in achieving this goal. So the take-home message is surgery has a significant impact on natural history of diffuse low-grade gliomas. Surgery improves quality of life. Reoperation should be considered more systematically. Objective assessment of the extent of resection. Especially you must look at the post-operative flare images. This is the one gives you a clue whether you got a complete excision. So please pay attention to flare. Just a complete removal of tumor is not enough. We have to get the flare part of the tumor also removed. And this is where your mapping comes. Provides neuropathological and molecular data, very important. Growth rate is crucial to decide when to do the next CT and RT, radiotherapy and chemotherapy. Objective neurocognitive examination is needed before and after such treatment. As I said, it is not just motor and sensory, but a lot of cognitive functions are important, and quality of life should be the first endpoint. Remember, it is not enough to have just power, it must have the complete quality of life of the patient. Remember complications all the time as you are operating on every patient of yours, whether it's glioma or any other. We organize these international conferences on complications in neurosurgery for the first time in 2017. And our highlights were anticipation, prevention, and management of complications, ethical consideration, philosophical aspects, moral obligations, legal implications, frank discussion on pitfalls of management. Not how I would do it, but how I would not do it, how I wish I had done it differently. We discuss all this on an open platform. And don't worry about failures if they are there. Failure is a defeat only if you don't learn from it. So share your information, share your failures with your colleagues on an open platform. And that's what we achieved during the first meeting, 2017, 3 days consecutively. We had something like 250 presentations in 3 days. And this inspired us to go for the second ICCN in 2019. And I am proud to say that the Egyptian Society was one of our sponsors and one of our promoters. And we had a host of others, all of them now jumping in to the fray. That means we found that our concept was acceptable by the whole world. Then we planned the third ICC, and unfortunately, it could not be physical, but we managed to have this meeting exactly on the same dates. It was a virtual meeting, again a 3-day meeting, 28 hours of conferencing virtually. And we have now gone into publication of the book on complications in neurosurgery. So the first conference and the second one. And now we are on to our continuous neurocomplications learning series. So we have done this in the last 1 year. Every 2 months, we are doing this neuro complications meeting and the next meeting. So we have tackled various important subjects. The next meeting will be after 1 week exactly on 28th of May on the same Friday at the same time as just now. We are going to discuss major complications with so-called minor surgeries, such as bowel drainage of chronic subdural, convexity meningioma, brain abscess, tumor excision in gliomas from non-eloquent areas, cranioplasty, VP shunt, EVD, ETV, lumbar disc surgery, endoscopy, anterior cervical disc surgery, carpal tunnel syndrome decompression. All these are comparatively minor procedures, and we are going to have invitation papers. If you have still got an idea, please send me an immediate message. We will try to secure your place, your berth on this very important meeting exactly on next Friday, and we will have a great time together. So I would say, Dhanyavad, as we say, thank you very much for listening to me, and hope to see you all again after a week at this very time. Thank you. Namaste.
Thank you very much, Professor Kiki Turel, for this great presentation. As usual, and all your presentations are always great. I know that Professor Kiki Turel, I have a list of 35 topics, and usually he gives me the opportunity to choose what topic he can speak about in all our activities. He is a regular speaker in all Egyptian meetings and in all African meetings, whether in person or online. Thank you very much. Would you allow me to follow the program and to do discussion after our last speaker?
Sorry. Thank you very much.
Thank you very much. And now it's time to listen to the Egyptian experience about cortical mapping in neuro-oncology, and Dr. Ahmed Ali Morsi.
Thank you, Professor Nasser. Is the voice is okay?
Yes.
Yes, thank you, and nice to meet you all, and thanks for the invitation. I'm really grateful for that. Actually, I'm going to talk about the brain mapping era in neuro-oncology and our recent experiences in Zagazig University in Egypt. Some of the information that had been already discussed in the previous presentation, so I'll try to be more unique in the points which hadn't been covered. Actually, when I discussed brain mapping with our colleagues in especially developing countries, they are saying that we need large facilities, and it's not easy to do it. But actually, I had the nice opportunity to meet Prof. Defoe and Prof. Berger, and they are unique and masters of this brain mapping. So it was very nice to discuss with them, and they told me that I have to start because all things are actually difficult before they are easy, and the greater the obstacle, actually the more glory in overcoming it. So I advise everyone to start in providing brain mapping techniques in his facility and trying to just overcome the obstacles. Actually, it will be very nice to have these facilities in your department. I'd like to thank my teams in neuro-oncology, multidisciplinary team and multidisciplinary epilepsy team, and nothing had to be done without them. And actually, they are actually assisting me very much, and nothing to be done without a multidisciplinary team. Just to go through the rationale of brain mapping techniques, actually, we are all the time in neuro-oncology trying to balance between the resection and preserving the function. And we have a lot of literature in a greater and more extent of resection in gliomas and in other types of tumors. So the more the resection, the better the oncological outcome. You have more actually literature in GBM, in even in recurrent glioblastomas. In 2016, when I was in Singapore, we published 2 articles about extent of resection in redo, even in recurrent high-grade gliomas. And there's also a lot of literature which is talking about the more functional and oncological outcomes in low-grade gliomas. And as we discussed in the previous lectures, the value of the extent of resection is increasing day by day. And actually, the technology is increasing every day, and modern neurosurgery is including a lot of techniques to locate and identify the lesion. And also, this had been covered in the previous lectures. Intraoperative ultrasound actually is to be used in my department for a long time. It's a very cheap and a very useful intraoperative real-time tool. And I advise everyone to have the facility in his department, and especially if neuro navigation is not available. So you can see that it's very easy to identify and locate the margins of the tumor, even if it's like this very small DNet in the motor cortex. Actually, it also can be identified in the ultrasound. You can see here that also the ultrasound can give you a sagittal view like the MRI, exactly like that, and a coronal view like that. And after you finish, you can assess if there is any residual or not. But the point of my presentation today is the functional outcome. So our knowledge of the topographical anatomy, as you know, and as we discussed before, that it's not sufficient actually to know the functional anatomy. Why? Because we have an inter-individual variations. Actually, our lack of data on inter-subjective variability. So our data about Brodmann's map and all these data are actually changing in the last time and in the last years. And actually, it's going to be a more specialized, individualized map for every patient. So you have always to think that your patient is not all the other populations, and there is an inter-individual variations between your patient and the other population. So the coupling between your knowledge about the anatomy and the function is the aim of our actually lecture today. The lesions actually can alter the understanding of neuroanatomy. So your lesion is actually a space occupying lesion, and it's making deformity of all the cortical and subcortical areas. The second is that there is a brain plasticity and reorganization of the function. So the redistribution of this functional is always going in the presence of a brain tumor. So you can see here in the very nice data had been presented by Nader Sonai and Mitch Berger, and they are talking about the variability of negative mapping of speech areas along the dominant hemisphere in their actually literature. And you can see that maybe like this area, which we are expecting that mostly it's a positive. It was negative in 84% of their patients. So it's actually an inter-individual variations. Also, it's not only the cortical areas, but the subcortical areas is very important and very essential. So there is no value to keep the cortex and cut all the cables which connect the information from the cortical area. So the subcortical areas are actually very, very important to know. And also in neurosurgery in 2011, there is the difference between awake craniotomy and surgery without any brain mapping techniques under general anesthesia. And you can see that the transient deficit was in those had been done in general anesthesia and related to eloquent areas was about 84%. But when you use an awake craniotomy, it was only 24%, and it was permanent in 4.6%. And when you are not using any mapping techniques, it was 16%. So the difference is statistically, of course, significant, and it's very important to know that. So when you think about doing any tumor related to eloquent area, you have to think about brain mapping techniques. And when we are talking about brain mapping techniques, it's not only the intraoperative, but also we have a preoperative mapping techniques, like we mentioned before, like functional MRI, DTI, magnetoencephalography, and navigated transcranial magnetic stimulation. But the problem is that you can have a very nice and a very wonderful functional MRI and DTI images like that. So this tumor, and you can actually identify the functional areas, and you can do a DTI for the tract, but and also in this patient, it's very obvious that we identify the area, but you have to know that the accuracy of all these techniques till now is only about 80%. So 20% of your patients, you will have a wrong issues or a wrong data or false negative areas and all these. Why? Because there is a limitation in the functional MRI and DTI. You have an artifact, you have a brain reorganization, and the most important in functional MRI, that functional MRI is only showing you the area which is activated during the task. but it's not mandatory that this area is necessity. Maybe you have two areas are actually activated during performing the task, but actually when you maybe lose one of them, the task is still performed with the same accuracy. So that's why we are talking that it's not actually very important. Like in this patient, we have an area here in the function MRI about comprehensive speech and picture naming, but actually intraoperative, when we used an awake craniotomy and speech mapping, it was a negative EVA and nothing had been done, and the patient had nothing and no deficit post-operative. Also, you have a lot of artifacts, like in this patient, this is the tumor, and you can see there is a lot of artifacts around it, and you cannot get an important information from that. Also in the functional MRI, when there is a lot of edema around the tumor and a lot of tumor infiltration, like in this metastatic lesion, you can see a lot of edema. So of course, the DTI is not accurate and it's not actually beneficial for you like that. So in those issues, and also in magnetoencephalography, it's very cost and it's not available in most of the centers, and navigated transcranial stimulation is very expensive and complicated. So the best one actually to trust is the patient himself inside the operative, and what we are calling intraoperative brain mapping. And the intraoperative brain mapping, it's not mandatory that the patient will be awake, and we will discuss in the next slides that you can do an intraoperative brain mapping with a non-awake patient. So you can have your patient awake or non-awake, but the mandatory issue is to use an intraoperative mapping techniques with the patient himself inside the operation. I'm using the mapping techniques in many modalities and with the different teams in epilepsy surgeries and in oncology surgeries, speech, central, visual, electrocorticography, determining the epileptogenic zone. All these issues had been actually developed during the previous years in my department, and we are doing all of them now. But the issue that today we are more concerning about neuro-oncology. So I'll be more concerned because of time about speech mapping and central area mapping only. Regarding speech, when we are talking about speech mapping, it means that the patient should be awake. There is no speech mapping without awake surgery. So awake surgery is mandatory in those tumors which are related to speech areas. And when we are talking about speech, you have to take off the old anatomy of speech and change it to the new modalities and the new actually language functional anatomy, which is talking about there is a dorsal stream and ventral stream and more areas, more than Broca's and Wernicke's related to speech. And it's more complicated in the subcortical tracts. So you can see how much tracts are actually being involved in the speech production and speech accuracy and all the modalities of speech. So you have to be more concerned about this. Actually, when we are doing awake craniotomy, we improved our techniques by time. So every year we are improving something in our techniques to make it more accurate and more actually beneficial for us as surgeons and for our patients as and a different environment and then a different modality and different actually experiment for the patient. So we are talking to the patient in a very detailed explanation before doing an awake, and we have a multidisciplinary team for that today. And when we started, we used an anxiety scale, which is called the STAY scale, and we used it to show how much anxiety is your patient and how much cooperation our patients will be. And we have an Arabic validation for this STAY since 1988, a very long time. So it wasn't difficult for us as a language barrier, but the issue is that day by day we improved that to have a very important and very detailed full neuropsychological assessment with our neuropsychology colleagues. So we are doing now the intelligence quotient, we have do attention and the visual verbal memory tests. We have a long language modality to show how much language deficits the patient has, and we have a social cognition modality for our patients. So it's a very detailed neuropsychological assessment nowadays. Before the awake craniotomy, it's very important to have an anticonvulsant blood levels to your anti-epileptic drugs and to give a minimal doses of sedatives and an anxiolytic if the patient shows some anxiety before the surgery. Everyone inside the operation should know that it's an awake craniotomy and to be silent. the nerve block is very important. So actually, we are doing a lot of changes in our scalp block because we are using what we are calling monitored conscious anesthesia. So the patient will be conscious throughout the operation. It's not non-awake, awake, and non-awake modality, but we are doing a monitored conscious anesthesia throughout the operation. So the scalp block is very important for us. So we are improving it to be an ultrasound guided, and we added some modalities with our anesthetic teams, and we published that. So with the anesthesia year by year, we published a quasi experiment about the difference between dexmedetomidine and midazolam with my anesthesia team. And after that, we published a very important article about the adjuvants, which you can add it to the lidocaine, bupivacaine, actually, to make the scalp block more efficient and longer time. And it had been published last year. We have a lot of issues regarding to anesthesia. We have to make sure that everything with your anesthetic team is going okay. You can bin your patient like that. So the patient with a bin, if you have an optical navigation or you have a non-actually cooperative patient and you have it, you need to be binned to the table. But we published it when I was in Singapore in 2015, an awake craniotomy without rigid bin fixation using the electromagnetic axiom navigation. And this modality actually like that. So the patient will be free, and there is an electromagnetic navigation is helping you, but the issue that the patient should be very cooperative with you and showing very low anxiety levels before choosing this. And we found that it's very a better experience for the patient having no bin. And actually, if you have any problem with the airway with the anesthesia, it allows a very rapid repositioning to the head during the procedure. So we used it in some patients. We are using for cortical and subcortical mapping a full neurophysiological device. So the intraoperative full neurophysiological device is giving us more modalities than the Osman stimulator. So we are doing stimulation. We are actually doing electrocorticography and doing grid, and in epilepsy cases, it shows more channels to have an electrocorticography, and at the same time giving you an updated issue about the level of consciousness of the patients. The bispectral index of the patient is to be evaluated by the anesthesia using these actually devices, whatever the actually it's Medtronic or Enomed or whatever the company. We are using a bipolar stimulator, and sometimes we use a unipolar in the subcortical stimulation, and it's a very detailed issues not to be talked about today. The task specific actually is very important. So not everything to be actually mapped, but according to the area, you have to choose what task you need before doing the language modality to the patient. We started with this. So the neurophysiologist will carry the actually the device or the screen and will do a manual language modality for the patient. But after that, like in this patient, so this patient, for example, showing an area of low-grade glioma, which is directly related to the motor speech area, Broca's area. And you can see that this is the tumor after delineation with the ultrasound. And this is the positive area, which gave us a speech arrest. And after that, we did a full total resection of the tumor and preserving this area. And this is what we actually was doing before, like that. So the neurophysiologist will make the screen in front of the patient like that. Okay, and after that, he will do that. And this is another example of an oligodendroglioma, but it's directly related in the depth to the arcuate fasciculus and related to the motor speech area. So also we did that. Sorry, it seems that something wrong in the video. But anyway, this is a third example of speech mapping of this anaplastic astrocytoma grade 3 in a young lady, and it was very large with intratumoral hemorrhages, and you can see the the MRI, and this is the MRI. And you can see with doing all these modalities, we had the chance to do actually a total resection, and this is a post-operative 4 years after the operation without any recurrence for this patients, and it was a very nice outcome for us. But after that, we improved our language modality to be more easier for the staff inside the operating room. So we had a screen in front of the patient like that, and it's mirrored from a larger screen in front of actually surgeon, and there is a mics inside the operating room to reflect the sound, and it's everything is mirrored and had been done by our IT. So it was a very easier experience for the surroundings inside the operating room. The second issue to talk about is the central area, actually, the motor and sensory mapping. And when we are talking about mapping for motor, it doesn't mean that we need the patient awake. So we can do the intraoperative mapping motor while the patient is awake or while the patient is under general anesthesia with the TIVA protocol, total intravenous anesthesia protocol. And our actually inclusion criteria is if the patient is fit for awake craniotomy, like age is okay, fluent in speaking and understanding, accepting the procedure, doesn't show severe anxiety or emotional instability in neuropsychological assessment, the language deficit is not greater than 30%, and fluent in speaking, and the mini mental state examination of him is more than 24. Actually, if he is inside this inclusion criteria, we are going to do it with awake craniotomy. But if he didn't meet these criteria, we operate the patient under TIVA protocol with intraoperative neurophysiological MEB and SSEB techniques. So this is another example. I think also the video is not working, but this is the intraoperative MEB in one of our patients, and it shows a positive MEB in the right hand and right thumb. So you can use it like that. Sorry, I think there is a problem. I'll re-share again. Sorry, is it okay now? So there is another example of motor related or perilorandic glioma like that, and basically we did a total resection for her after motor mapping while patient was awake, and this is a patient immediately post-operative, and you can see that 1 year post-operative it was okay and without any recurrence, and basically 3 years also post-operative the patient is doing well without any recurrence, and she is okay. Another example of motor area also which had been done while patient is awake is this low-grade perilorandic glioma. And you can see that it's directly related, and we had a functional MRI and DTI for her. And you can see that the corticospinal tract was actually in front and behind the tumor. And we did, and this is a 2 years post-operative, and patient is okay. Even this a very small DNA in an epilepsy case, and you can see that the patient was awake inside the operation, and she is okay post-operative. But in this young, actually 9 years old female with intractable epilepsy and xanthroastrocytoma, and this lesion was directly related to the motor cortex. So we did a general anesthesia with the Artiva protocol and the intraoperative MEB and SSAB with strip electrocorticography. And we did a total resection actually for her, and patient was okay post-operative with a full power. And 2 years post-operative, she is still in a good condition without any recurrence. In our data, in 75 actually awake cases, whatever speech or motor, you can find that the mean range of our extent of resection was 94.3%. And the gross total resection actually more than 98% was in 46%. And our worsened deficit actually was immediate in 23.3%, but after 3 months, it was only permanent in 6.7%. But when we recruited 64 patients, of our patient underwent perirolandic glioma. So we had 40 awake patient and 24 general anesthesia with Tiva with motor mapping for perirolandic glioma. We had actually a worsened deficit in immediate in 37.5%, but it was permanent after 3 months and 5% only. And it was in the general anesthesia 45.8% and permanent in 8.3% only. And we recently published, and I advise everyone to read our experience in perirolandic glioma resection using intraoperative mapping techniques, whatever general anesthesia or awake craniotomy. And we published the predictors of stimulation-induced seizure. As we previously discussed, the stimulation-induced seizure are actually a very important complication intraoperative, which we can have during intraoperative mapping techniques. And we had actually during awake craniotomy 10% of our patients, but in general anesthesia 12.5%. And we actually recruited that or explained that the cortical stimulation threshold when the patient under general anesthesia actually is more, and the more stimulation threshold is the more maybe complications of intraoperative induced seizures can done. And the predictors for our patients, actually those patients who had a multiple previous history of multiple anti-epileptic drugs and those with low-grade gliomas are actually positive predictors to have a stimulation-induced seizures. And you have in those especially patients to be ready for this complication with a cold ringer saline, and your anesthesia will be ready for some sedation if it's not controlled. Actually, at the last, I'd like to say that those patients with eloquent area tumors are actually doesn't have hope, and many surgeons are frightening them and making them very fear from the operation. So our rule actually is to provide these mapping techniques to provide them the hope for a safe operation. And the multidisciplinary team is very important in such issues, and team is many hands but one mind. I'd like to thank my patients who are actually improving me to improve myself every day, and my team of neurophysiology and anesthesia and my colleagues in neurosurgery departments. And thank you, everyone.
Thank you very much for this interesting presentation, Ahmed. Now we open discussion. I think we can have 5 minutes discussion. We close the webinar at 4:30. Professor Tiki, do you have any comment about Egyptian experience of Ahmed Mursi?
I think it was an excellent presentation. I really enjoyed it, and I concur with most of these. I think we belong to the same school of thought of Mischberger and Dufau. We have been close friends for a very long time. So unfortunately, it's not, I mean, looking at Dufau's technique, he swears by this fact that he does not do anything except brain mapping. It does not believe in any other preoperative evaluation in terms of DTI or MRI or so on. But I'm sure Dr. Ahmed Morsi also will agree with me that we still will like to do that so that we can get the maximum information on our table, and then we choose what information we want to use. And I'm not saying that we are going to sacrifice our brain mapping techniques because of that information, but we will use everything together. I must also emphasize the importance of very simple ultrasound probe, because it is real time and it keeps on helping you during the operation, throughout the operation, especially in insular area. You do not know whether you've really got the entire low-grade glioma out or not. It's very sometimes very defeating to see that what you think was normal brain, but actually on the scan post-operative, it looks like a residual tumor. So ultrasound can be very helpful. I don't think it can be picked up. Low-grade gliomas can be picked up very well by 5-ALA or even by fluorescein. I'm using fluorescein. I don't use 5-ALA because of the cost. But again, the same handicap in low-grade gliomas, they are not so helpful. I would like to know if what Ahmed Morsi or anybody else has to say about it.
Yes, thanks, Prof, for the comment, and I emphasize also pre-operative mapping. Actually, I see that the pre-operative mapping and the intraoperative mapping techniques are actually cooperating together to give us more information, and once it's available, it's recommended to be done. So the pre-operative mapping is important, but it's not a substitute to intraoperative mapping if intraoperative mapping is available and the circumstances is okay and the inclusion criteria is okay for it. The second issue, actually, ultrasound is a wonderful tool. I actually emphasize it and recommend it for any especially center which doesn't have a navigation, and it's very nice, but it needs some training issues, which by time will be more and more easy to use.
Thank you, Ahmed. Professor Cordoba, do you have any comments?
Nasser, may I ask a question?
Yes, please,
Yes.
go ahead.
What is the youngest patient anybody over here has done with awake surgery? I mean, we all say nobody less than 18, but what is the youngest patient that you have done, Ahmed,
for me in epilepsy surgery, it's different. So I had a patient with epilepsy surgery, and he was only 10 years. And we did him in an awake surgery, and he was very cooperative, but it differs from a child to another. So in such patients, I have a pediatric neuropsychologist. He is a wonderful one, and I'd like to thank him, Dr. Mona. She is doing a pre-operative pediatric neuropsychological assessment, and she talks to me. But for me, he was only 10 years, and he was very cooperative but he was an epilepsy case.
Very good, very good. I agree with you.
Which is the experience of the colleagues in musicians, patients versus non-musician patients? Because normally the musicians had a lot of very, very eloquent areas, normally with much more plasticity in the brain than the non-musicians patients. This is very challenge for the neurosurgeon normally. If you try to compare, we have a lot of different cases and different papers published with this kind of examples within non-musicians patients and musicians patients. That's very interesting, I think, mainly in this kind of surgery.
Any other comments, Professor Abdelnabi?
Only to congratulate Professor Ahmed Morsi. Very good work, and I think the four or the three speakers about wake craniotomy or brain mapping, we have to work and to go ahead to improve our results and the outcome of our patients. Thank you.
Yes, sure. Yes, sure. Thank you.
Thank you very much. Any other comments? I would like to say an important comment. Professor Kiki Turel, he texted over the chat panel. It's very important to give an excellent scalp block by an experienced anesthetist for operating on patients awake. And that's very important message to everybody who would like to work on such subspecialty on functional neurosurgery.
Yes.
I think by such very kind advice and very important recommendation of one of the masters of functional neurosurgery, it's time to close this webinar. And I think it was very successful scientific activity. At the end of this session, I would like to thank all our speakers, Professor Kiki Turel, Professor Abdelnabi Ben Isa, Professor Alvaro Cordoba, and Professor Ahmad Mursi. I would like also to thank my organizing team, especially Engineer Ahmad Magdi and Dr. Hassan Ala. Really, you are doing a very good job, and we are doing a very important activities and this series of webinars. I thank all our speakers, and I would like to thank all our participants to making this event successful. Thank you very much, and hope to see you soon again in another occasion. All of you, thank you.
Thank you, Professor Nasser El-Ghandour.
Thank you.
Thank you to all and stay safe, please.
Thank you very much.
Have a good day.
Thank you.
Thank you so much. Bye-bye.
Hope to see you next Friday.